Now, I am starting to record this, so if you are okay with this being recorded, please stay on. Again, welcome to Bananaz, Ukraine. My name is Dr. Maksim Shapiro. I'm here with my mentor, Dr. Peter Kim Nelson. Many of you know Kim. Kim is upstairs. They're working now. I broke off to do this, but we are in Kyiv, in hospital number 1 in Kyiv. And Kim is upstairs. They're doing a case. So this is Bananaz, Ukraine. Bananaz, Ukraine is part of our mission, which Kim and I have been doing for over a year, where we're helping with various cases and doing work in Ukraine. We have been to Lviv. We did some fantastic cases in Lviv. Now we're in Kyiv. Later on, we'll be heading to Dnipro to do more there. It's really been a great mission so far. It's enabled by an organization called RAZOM for Ukraine. RAZOM for Ukraine does fantastic work in many different aspects of support for Ukraine, including this co-pilot mission. The co-pilot mission has many arms. Neurovascular is just one part of co-pilot. There is ortho co-pilot, there's open neurosurgery co-pilot, there's face-to-face, which has to do with basically like facial trauma and reconstruction and injuries related to combat. We are here to show some vascular cases. What we'd like to do is review the cases that we did. I'm going to show what we did and why we did it. We want to make this interactive, so please ask questions. You can ask questions in English. You can ask questions in Ukrainian. There is a button in the Zoom. You'll see an option with a button that looks like a world, like a Mercator projection of the world. You can select it and select Ukrainian if you'd prefer to listen in Ukrainian. Sava is our interpreter. Sava, thank you so much for doing this. So, if you have questions, ask, or you can also ask the questions in the chat. So if you look in the chat, let me take a look here. See if there's any questions so far. So far, none. Okay, so here we go. So we're going to look at some cases. These are some cases we did in Lviv, so we'll start with this case. This is a young woman with an unruptured, with an aneurysm of the right middle cerebral artery. We have this CTA. She's had several episodes of headache. It looks from the CT that this is a ruptured aneurysm, said unruptured. It's a ruptured aneurysm. It's ruptured perhaps 3 times. Now, it's not been despite this, she's neurologically intact. The rupture has been small. And so what we see on this image is, if you guys can admit people into, like, just hit admit all, whoever is the co-host. Is there a co-host to admit everybody? Or I can do that myself. Okay, so you have a CTA that shows a partially thrombosed aneurysm. These are some of the tools that we had used for this. Okay. Oh, actually, let me see. I don't have the more images of this case. So we're going to come back to this. Let's look at this one. This is another great case, actually, that we can spend some time on. It's a woman that comes in with transient issues with swallowing. We'll come back to all the tools that we had used. This is her MRI. On this MRI, we see a mass related to the brainstem. There is brainstem compression. You can see some signal change in the brainstem back here. And so from looking at this, it appears to be that this is likely an aneurysm, a large aneurysm, probably fusiform, compressing the brainstem. Here's the MRA. You can see the same here. There's a rim of hemosiderin around this. And so one of probably the very striking thing that we see when we see this first is how well this person is doing, considering how much mass effect there is. it tells us that the mass effect is likely very long-standing. Here's a CT. Now here's some select images from the CTA. Reconstruction of the CTA. We see this kind of like, it's a little bit hard to see what's going on in here. Obviously there's a big aneurysm, here's two vertebral arteries, but how this whole thing comes together is not really clear. You see some measurements. Here's the angiogram. Now this angiogram is made from a strong injection into the left vertebral artery, which overcomes the inflow from the right. You can see this big aneurysm. You have to sort this out. A lot of this has to be sorted out. Now, fortunately, in this case, we have the possibility of doing a 3D image. There's a rotational angiogram that we can do. This is a Philips machine. And so it allows us to do a rotational angiogram, which is something that's very important to try to figure out how to attack this and try to sort this out. Obviously, you can see these branches. What's important to recognize here is where these branches are coming from. This looks like something like an ICA. Like, how do you sort this out? And here is basically the best that we can do on this machine, which is quite good in terms of looking at this in 3 dimensions. So what we did is, now there's different, if you're looking at Philips, Philips machine has like a standard rotational angiogram. There's also a vaso-CT option. Now the vaso-CT option is a longer injection option, but it's an option that allows you to get a better picture because it has a higher resolution. And we do need this here. I think it helps. So even already when we look at this aneurysm from the back, this is looking from the back side, so these vessels are on the left, not on the right. You see that there's something a little bit strange about it. Like, here's the vertebral artery, here's another vertebral artery, here's the basilar. These two ICA-like vessels, which this one is more like the true ICA, this is a pica-like vessel, are coming off distal to the aneurysm. But what's going on in here? It's a little bit interesting and unusual. You have this kind of limb here, you have something else in here. Looks like it's coming into the aneurysm. So we have to really analyze this and spend a lot of time figuring out what to do. Now, here is another image. Like, again, it looks like there's some limbs. Let's go back to this. And so how do you put this together? And basically, if you look at this from these different perspectives, what we realize, if you go back to this, you realize that this is not a basilar aneurysm. What this is an aneurysm of the vertebro-basilar junction. This is really a vertebral artery. This is another limb of the other vertebral artery with an associated pica right here. And you can see that from a projection in here. And so this is an aneurysm that really is not a basilar. It's an aneurysm that comes from the vertebral-basilar junction, and it has to do with an anatomical variation of the vertebro-basilar system that's called a fenestration. And so if you imagine that there is a fenestration, that there is a connection between these two vertebral arteries down here that essentially gives rise to this aneurysm, and the aneurysm fills the space between the fenestration and the vertebro-basilar junction, then you start to understand how this aneurysm is put together. So here, it's very hard to understand this unless you have a rotation, and unless you have this more advanced imaging, which is important if you're going to tackle this kind of aneurysm. Now later I'll show you another thing that you can do when you don't have rotational imaging, but it's very, very helpful. So now once we understand this, we can think of a strategy, like what kind of strategy you can have. Now one strategy is basically like, maybe surgical ways of doing it. If we're thinking of how to do it from an endovascular perspective, the best way to do this is with flow diversion, using a device like the pipeline or other flow diverters that you may have here. Now we prefer to use the pipeline. That's what we're going to use here. Now, once we understand how this is put together, you realize that you could use flow diverters from either one of these limbs. So we can put a flow diverter from this vertebral artery here into this one, like this, and then, or we can use one from here and here. There are different options that we can have. In the end, which one to use kind of depends on all these vessels, like preservations of the vessels that we have to preserve. For example, we have to preserve the perforators or the vessels coming off these limbs. So in this case, what we did, so now we come back here, what we are doing is we're coming in, this is a view from the left. So we're coming in from the left side. We have an intermediate catheter here on the left. We're coming up into the aneurysm now. From here, we are able to pass this wire, which is an Aristotle 18, which is an excellent wire for this kind of work, because we're going to use a 27. We're going to use a Phenom 27 catheter to get around this aneurysm. And so we're coming in, and we're able to put this wire from this left vertebral artery into the distal left vertebral artery up here. This is not in the aneurysm. This is really in that distal limb of the vertebral artery. And you have to know that you have to go back to the 3D to understand that. But that's where this wire is. Now this, it makes a loop-to-loop. Now it loops inside the aneurysm and then finds its way out into the right vertebral artery like this. Now when you do this, right, what it enables you to do is take your 27 catheter and go around and get into this right vert from the left vert. Now we're going to do this because what the strategy is going to be is to build a pipeline construct from the right vertebral to the right vertebral here, and then from this left vertebral to the left vertebral here. So that we have bilateral, we are reconstructing, essentially we are reconstructing the person's normal original vertebral arteries and excluding the fenestration which gave rise to this aneurysm. And this is what we did. So we have a 27 catheter up here. Now, once we got the 27, once we got the Phenom here, we couldn't reduce it. We have this loop-to-loop. We can't reduce the loop without deploying something here, which we deployed. We're deploying a penumbra stentriver up here, which has good radial force to allow for basically very uneventful reduction of this 27 to be able to reduce this loop. And so that's where we have that. Here's like a still shot of that. And so that's, we came in, and now we're going to skip. There's a lot of steps that we do. And so in the end, what we did is we put this, we have two pipelines, two overlapping pipelines in this segment, two overlapping pipelines in this segment. So this is right, this is left. Here's aneurysmal stasis. So we got this picture basically to show you what this kind of thing looks like. Now, we can end the procedure here. Now, that's always a question, like, do we have to coil this as well? Do we just leave it like this and hope that it deflates? We weren't so comfortable with that. So from the start, we decided that we were going to coil this. And so what we did before we did this catheterization that I showed you above, we had catheterized the right vertebral artery, and we placed a microcatheter. We trapped a microcatheter, which you see up here. This, you see this distal tip of this microcatheter in the aneurysm. And then once we had put in these pipelines, this allowed us, and so here's a picture of what was done. Now here we're going to see this on the videos. See if we can play the video. Now we're doing this. So basically what we're doing is we're filling the space with coils. We can't put coils through the pipelines. It's not like a stent device. You can't put a microcatheter through the pipeline device. You have to place it, you have to trap it, which is basically place it into the aneurysm beforehand and then fill it with the coils. So here's the end result. The end result is a coil and several pipelines like this. Now it's a complicated case, and we started with the complicated cases because we wanted to give it a lot of time and make sure that we were there for the couple of days while we were still in Lviv to make sure that the patient, if there's any issues, that we were there to address them. And so here too, we're starting this Bananaz with a very complex case. I think it shows a lot of different points here. There's anatomy here. There's imaging. Different kind of treatment strategy. So there's a lot. If you have questions about this, please either speak up or you can type them into the chat. So if you go back to the tools that we used up here. This is what it took. It took a lot of tools, right? You have a Neuron Max on one side, Phenom Plus, which is an intermediate catheter, the Phenom 27, which is a catheter for delivery of the pipeline devices. Aristotle 18 is the wire that we used. And the Vigo is the 14 wire that we used to place the coiling catheter. The Chaperone is the guide to go into the right vertebral artery. There's an SL10 that we had used for this, the coiling microcatheter. 4 pipelines and lots of coils. Now there's some coils that have a name. I have them down there. They're basically a microvention knockoff coils. And we used 7 of them. And we have 1 microvention genuine coil and 2 angioseals. Okay. Mikola is asking a question. Do you prefer to add small doses of NOAC to adapt after basilar flow diverter stenting? Good question, Mikola. So generally, sometimes yes. It is a strategy that people use sometimes. In this particular case, we chose not to do that because this is not like, as it turned out, we thought like what kind of aneurysm this is. It turns out not to be a basilar aneurysm. This is really an aneurysm of like this vertebral fenestration. Now, we have another case where we do have a fusiform basilar aneurysm where we also didn't use a NOAC or DOAC. I think that's a good strategy sometimes. We really is not enough cases to really know what to do with them. I do think that if we're going to use like some sort of anticoagulant, then you have to also use, like people use triple therapy. I'm not sure about necessarily needing triple therapy. You could. Or you could use an anticoagulation and a strong single antiplatelet like Brilinta. Fortunately, we have, there's availability of Brilinta here that enables us to do all this. So all of these patients, this person here, were pre-medicated with Brilinta and aspirin, and that's important. Now we can get into like what's going on with with that. It's extremely important to have good antiplatelets for a case like this. Unfortunately, or currently, there is a shortage of IV antiplatelets in Ukraine. Integralin is really not available. Neither is Aggrastat. And so it's, to do a case like this without these medications is a little bit difficult because we're basically taking a chance that we're not going to have an acute thrombosis. I think we can kind of move on. If there's any questions that come from that, we can address them later. So just to scroll you through this again, we're recording this and it will be available online. So you want to spend time to like think about this and understand this case because it's probably anatomically, this is probably the most complex case that we have done. And so it's a little bit, it can be challenging. For a case like this, just to continue on the medical management, which is very important, you'd like this patient to be on dual antiplatelets for a minimum of 6 months. Generally, I prefer longer. I prefer at least a year if everything is okay for this kind of vertebral aneurysm, definitely for the basilars, which are, can be even more complicated. So far, we did this, I think we did this on Monday. So far, so good. Patient's doing great, which considering everything, the clinical presentation, which is basically like intermittent swallowing issues, is already kind of really fantastic considering how much mass effect there is. And so we have this, she's doing well. And so hopefully that will continue. Okay, questions about this case? If there's no questions, now we're going to go through all the cases that we did. Some of them I'll spend more time on. Some of them I'll spend a little bit less time on. This is a case of someone who had an infection, a cavernous infection. It's a complicated medical history, but essentially what brings him to medical attention is this giant cavernous aneurysm. It's partially thrombosed. He's got a full third nerve palsy, full cranial nerve palsy, 3, 4, 6. Has not a full numbness, but there's almost a trigeminal dysfunction as well, like mostly hypo, the loss of function. There's not a trigeminal neuralgia. And so at this stage, basically the question is what to do. This was even larger, kind of continued to increase the thrombus component of this. It's been going on for several months. We've been kind of looking at this case, figuring out what should we do. So in preparation to doing this, we had basically asked the colleagues in Lviv to do a balloon test occlusion, which they did. The patient tolerated the BTO very well. And so the question is now, do we reconstruct this or do we deconstruct? Here's the angiogram now. In the angiogram, you see the angiographic equivalent of a past balloon test occlusion, right? This is somebody who, when you're injecting the vertebral artery, you see a very good posterior communicating artery, a pacifier in the middle cerebral territory. So you know this is the frontal view of an ICA injection. You see a stenosis here. You see kind of like some contrast going into the MCA. But you see that that the person has a good PCOM. And so this corresponds to like a clinical balloon test occlusion that was done with balloon inflation and clinical exam that he passed very well. And so what we did in this case, if you go back, I think we have our tools here. So the tools we used, the Shapiro 17 microcatheter, we used the Dnipro, which is a flow diverter. Now the Dnipro, in this case, we did not start this person in dual antiplatelets. And so sometimes, it's not something we were thinking of, like how to make sure that we close this aneurysm with not so much material. We don't want to put too much coil inside the aneurysm because we want it to deflate and relieve the mass effect. So one strategy that can be done is to put the Dnipro without antiplatelets. Now, the Dnipro does not have surface modification at this point. And so the Dnipro is placed beyond the aneurysm into the paraphthalmic ICA, and then some coils are used inside the Dnipro to close this artery. There are many ways to skin the cat, many ways to close a vessel, but I think it's important to have distal occlusion and proximal occlusion so that the aneurysm does not backfill. And so this is one way to do this. And here's some angiograms after. So here's an injection from the left. You see that the anterior cerebral territory pacifies as well. Here's a frontal view of the injection from the left vert, looking at that. All right. Any questions so far? Okay, we're going to skip this case here. Here's a case of an A1 aneurysm. So this is something that is maybe like a little bit less unusual. Probably the only thing that's a bit unusual about this case is that the aneurysm is not an ACOM. It's really a fusiform aneurysm of the A1, which you can see better on this view, kind of like an ipsilateral oblique view. You can see already this is a case that was also treated with a flow diverter with a pipeline device. You come in here and place the pipeline across this A1 segment. The pipeline is placed a little bit proximal to the ACOM junction, which allows you to maintain patency of the ACOM, and close, hopefully these aneurysm. All these cases were done just earlier this week, so we don't have follow-up. We're going to get follow-up later. The chance of occlusion in this particular case is over 90% with a single pipeline device here. Okay, Mikola is asking a question. Is it always safe to reconstruct a vessel during active infection? So yes, so that was the question. Like another question is like, the infection, we were told that the infection is treated. But one of the concerns was like, do we try to reconstruct it or deconstruct? And we're still placing material in there, right? We're still placing a foreign body inside the vessel. If there's an infection, could that continue to be a nidus? Would that make an active infection more difficult to treat? I think that always comes up. I will say this, that like when we're dealing with mycotic aneurysms, right? When we're closing, like when a mycotic aneurysm ruptures, or even if they're not ruptured, so like distal aneurysms of the circulation that we're asked to intervene on. The intervention obviously involves placing some kind of foreign body, like either gluing them or onyxing them or putting coils in there, whatever it is. And obviously these are very actively infected people with active endocarditis and septic emboli. So my guess is that probably it is safe. As much as we know, the outcome of the patients with like mycotic emboli from endocarditis is really not determined by like continued infection of these aneurysms. It's more about giving them broad spectrum antibiotics or whatever and taking care of the nidus, replacing the valve or cleaning up the valve to get rid of the infection. The intracranial part, I don't think it's not really common for it to form abscesses or continue to be infected. So probably the answer is yes. Obviously, this is kind of a unique case. This case is another kind of complex case, and it brings up a lot of points. Again, if you have questions, this is something to discuss. This is a young man who actually came in with, about 6 months ago, he came in with a subarachnoid hemorrhage. And it was related to a rupture of a basilar aneurysm. Now, at that time, Group Lviv did a very nice job partially coiling this aneurysm to protect it. And because the aneurysm, you will see, the aneurysm is very complicated. Rightly, the strategy is not to do too much. Put in the coils, protect the rupture site, come back another day. And it's a unique case, but it's oftentimes when there is a strategy to deal with something in a staged fashion. You want to think of the case as like everything in total. Like how much risk do you take in the first stage versus second stage? If you're doing something like a plug-in pipe, which is what this is going to turn out to be. But if there's a plan to stage something, we want to minimize the risk of the first stage. And so I think this is what they did very well. Put some coils into the ruptured artery, portion of the artery, and then the question is, what do we do? We'll come back to the tools that we used. This is basically the aneurysm. So the aneurysm this is an oblique view of an injection this is from the left vertebral artery. So this is the left side. And this, here again is this is now, if you look at this picture, this is a turned, like a kind of like a different projection of an injection from the left vertebral artery. And it shows you best what this aneurysm looks like. These are the coils in the previously ruptured segment. Obviously, it looks very hairy. It's a likely dissecting aneurysm that involves basically the entire basilar. Now here, if you notice, there is, this looks relatively normal, if you will, more normal than the other parts, but it is more dilated than perhaps I'd like to see. In this picture, This view is the view from the right vertebral injection. We're refluxing into what is perhaps a slightly larger left vertebral artery. Now here you see that the aneurysm begins at the vertebrobasilar junction, so both vertebral arteries are contributing to this lower aneurysmal segment. There's a large pica coming from the right here. Here's a corresponding ICA coming from the back. Now we have to work this out. Lots of perforators here. Now fortunately, the top of the basilar seems to be like relatively reasonable at this point. So the question is how to treat this. Now there's no, now one more thing that we should mention, and it's important, is that you see a vessel here. And this is kind of like back projecting, but there's another one up here. These vessels are the posterior communicating arteries, which we are looking at retrogradely. So here's a right PCOM, here's a left right PCOM, left PCOM. Small but present, and I think that can be important. Now, if we're thinking of like reconstruction for this vessel, basically the only option is flow diversion or some sort of reinforced stenting. The question is how to do it. Like there's a lot of different options. We were talking about like triple therapy, what to do. Which one? Now, the basic, there are two like kind of basic angiographic features of this, or anatomical features that we have to understand. One feature is we have to understand whether both vertebral arteries, what is the inflow into the aneurysm and what is the outflow. In order to treat an aneurysm effectively, we basically have to eliminate all areas of inflow into the aneurysm other than the one which we're going to be using for flow reconstruction. So in this particular case, if we're going to put a flow diverter from the top of the basilar to, say, the left vertebral artery, we have to close the right vertebral artery. Because if we don't, what will happen is this artery will continue to supply flow into the aneurysm, will continue to have antegrade flow into the aneurysm, which will keep the aneurysm from thrombosing or ultimately shrinking or remodeling. And it might even increase the risk of this aneurysm growing because it will be more pressurized from the right vertebral injection. That's point number one. The point number two is to see what happens with all the perforators. We have to understand what happens with this ICA and what to do and how to, can we jail? How can we cover some of these vessels? If there is, for example, a very large aneurysm and if there's no way to reconstruct it to oppose the flow diverter to the ICA, it becomes a much more complicated, much riskier case. Now, the kind of twist, if you will, in this case, is that this particular machine at the center where we're working on does not have rotational capability. So we have to work this out based on kind of like old school, like 2D angiography, choosing different angles and seeing what to do. So just by turning camera and looking at the projections we get, we're able to understand what happens to this ICA. So we got a projection where you can see the origin of the ICA in relation to the basilar artery, which was very, very helpful because now we can see that it looks like we could use a flow diverter to successfully kind of like reconstruct it to oppose the end of the flow to the edge of the diverter to this ICA. Now, I'm spending a lot of time like describing this because I think that in cases like these, thinking about it and like choosing your strategy is more than half the battle. You have to execute, but you have to have the right strategy to this. So the treatment strategy is paramount. Now we go to the treatment. Now we don't have the videos. We haven't really saved a lot of those, but basically what we do, the treatment is going to be this, is that we're going to come up from the left vertebral artery into the aneurysm, catheterize the aneurysm. We're going to place a flow diverter from the top of the basilar, below the superior cerebellar arteries, into the left vertebral artery up here. Having done that, we have to now close this right vertebral artery, and based on the best 2D angio that we have, we believe that closing this segment is going to be safe up until the point of this pica. Now, there is some sort of anatomical hunch that this is going to be okay. And the reason we think it probably will be okay is even if we don't have the resolution to see the very small perforators in here, we know that if there is a classical pica that comes from this proximal intradural vertebral artery, it is less likely that we will have medullary perforators from the segment here. Had we not had this big pica, had you had like a big pica here, for example, there would have been a far greater likelihood of having one of these perforators here that you don't want to close because you can have a Wallenberg type of syndrome or worse. So, this is important. So you can use anatomy. If you don't have like the full imaging capabilities, you can kind of like hedge your bets in terms of what could happen here. So this looked like a favorable situation for placing the flow diverter into the left vertebral artery because we had a pretty decent thought that we might be able to close the right. And so this is what we did. Here's a image. So we're using, this is like a DFT kind of flow diverter. It goes up to 6 millimeters in diameter, which we can bring up here. We allow it to expand into this aneurysmal segment. Actually, it's good to do that. It doesn't, you might ask yourself, like, why are we pushing this thing here? Why don't we want to like reconstruct it into a more homogeneous looking basilar? And the answer is that it's important to oppose the walls of this aneurysmal segment as much as you can, because I think it reduces the risk of thrombosis in between the aneurysmal segment and the flow diverter. And I think it makes the procedure, safer. This is a very high risk undertaking, both in terms of the procedure itself and the postoperative care. And so anything we can do to minimize that is important. So here, I don't know if you can see this well, but basically what you have is like it's a long device. We've come down, we've expanded it well here, but there's a little stenosis. Here it's starting to twist a little bit. And so we can't really open it fully here. It's kind of partially open, but there's a stenosis. Now, the question is what to do. We spent time unraveling it. We were able to get this twist, which started up here, to kind of like milk it down here with pushing and pulling and wagging and all these terms that we use when we deploy flow diverters. And we come down here. Now, once we had kind of deployed it completely, you notice that there is still a stenosis here, right? If you do an angiogram, go back, other pictures. So you just have to trust me that this is not how the vessel is. The vessel is more like this here. And, do we leave it like this or do we try to open it? It's always a question like, is it good enough? Is it not good enough? This portion is in the vertebral artery, so the length was good. The only question is what to do with the stenosis. I think in a case like this, you want to do a good job. Like if there's a way to get rid of the stenosis with relative safety, I think it's a good idea. So we tried to do that. We used a compliant balloon, which didn't really work. We used a non-compliant coronary balloon, which kind of opens the stenosis, but then it closes again. This is a braided device. Now, braided devices have this property that you can't really just open them the way you could open like a coronary stent, like a laser cut stent. This thing, in order for this stenosis to improve, it has to untwist. And whether or not it can do that is just like a really complex question. Depends on its radial force, depends on a lot of factors. So either it's going to work or it's not. And so having ballooned it for like 20 minutes or so, realized that nothing, it ain't happening. And so in the end, we decided that the best thing to do would be to open it by placing a coronary stent inside this flow diverter, which is what we did. It's an onyx. Now, it doesn't have to be drug-eluting. It happens to be drug-eluting, but it doesn't really matter in this case. And so we place an onyx stent into this segment, and you see that it does a good job, opens it quite well. Now, after that, we'd post-dilate it a little bit at the bottom and make it a post, make it really nice. But basically, this is like kind of an extra step that was required to make this good. Now, having done that, the next step was we had pre-placed a microcatheter, again, from the right vertebral artery. We had pre-placed a microcatheter into the aneurysm. So this required, again, just as in the first case, you had to catheterize from, you have to have like two groin catheterization or radial. One was radial, one is femoral. And so here we're placing, we've placed some coils into the aneurysm, not too many. Mostly it required just like closing this segment. And you see it takes a lot of coils to close the vertebral artery. There's other ways this could have been done probably, but I think coils are fairly safe. And so here at the end, we have like coils coming up just to below this pica. So the pica is patent, and you have to close this vert. I think it's important. A lot of times I hear like, okay, we've put a flow diverter, can we stop? Like, is it okay? Let's try it. The answer is no, you can't. Like, we've basically like left the aneurysm more pressurized than before. Really have to finish it, close this thing. So this is what we have at the end. Let me play this. You see how you have more contribution from the PCOMs up there. The aneurysm, there's a little stasis inside this segment of the aneurysm that's now like covered with the flow diverter. The pica is fine here, and you saw previously that the pica is patent. So it's a complex case. We are so far so good. It's been a week, less than a week, about 6 days. So far he's doing well. Staying on dual antiplatelets, 90 Q12 of Brilinta and I think 75 of aspirin. We're going to continue this in this case. Probably, right now the plan is to do this for 2-3 years. Dual antiplatelets, I think that's what's required so far. We've, we're good. Definitely we're not out of the woods. A case like this, issues with healing can come up, weeks, months afterwards, especially if the dual antiplatelets are not adhered to. So we had a long talk with the family, telling them that he must take the medications. If there's any concerns or questions, you have to talk to his team. Any changes to this medication have to go through the surgical team that did this. Okay, I think this is the last slide of this particular case. It's complicated. So this case and this other, the first case I showed, is one of the most complex cases we've done. Any questions? You can ask, if you have any questions in Ukrainian, I'm able to hear. Let's keep going. We have a lot more cases that we can kind of review. I'll spend more time on some of them than others. We did some diagnostic works. You see some AVMs. Here's a cavernous fistula that's spontaneously closed. Now, in looking at that case, we did find this particular anatomical feature, which I think is important to know. Not everybody's familiar with something called the carotid web. This is a classic carotid web. This is not atherosclerosis. You see how nice and smooth this is, how it has this lip like this. This is a lip of connective tissue, of fibrous tissue. This is not athero, and it's called a web. Now, the web, it's probably related to like fibromuscular dysplasia spectrum. It's often found incidentally, as it was in this case. Sometimes they can cause ischemic issues. They can cause strokes. The way they cause strokes is by creating a stasis of flow in this area, like back here, behind the web. And the webs, like anything, come in different shapes and sizes. They can be very large or small. They can be long and thin. And so if a web, instead of being like this, is a little bit taller, like that, the taller they are, the more stasis exists behind the web, and that can cause clot to form just because of stasis, and that can embolize distally and cause a stroke. Particularly in younger people, this is something to look for. They can be difficult to see on CTA. They can be quite difficult to see. Even an angiogram, if an angiogram is not done in the right way with the patient holding still, this one was under general anesthesia, but you don't have to do it under general anesthesia. You just have to use good technique, either tell the patient to hold their breath or stay, not to swallow and hold still. You can miss these. Recently, just a few days before we were leaving for this mission, we had a very nice case of that, that my colleague Vera diagnosed from a young woman with a couple of embolic infarcts, a very, very thin web. My other colleague Aras took it out. The way to treat webs is basically, in terms of intervention, if they're incidentally found, you don't have to necessarily do anything about them. If patient comes in with ischemia, and we think it's an embolic issue, like an artery-to-artery embolism from the web, they can be stented or they can be operated on. Certainly stenting is safe and effective, and we like doing that. Surgery is also quite effective, and one advantage of surgery is that you can have pathologic confirmation. You can send the tissue that you excise to pathology and see if it's ather or connective tissue. Most of the time you can tell under the microscope, when you're in the operating room, what you're dealing with. So indeed, it's a nice surgery, and they don't have to be in dual antiplatelets for that. So there are different ways to manage this. As a stenting, it's a relatively low-risk stent, right? Because you're not stenting an atheromatous lesion, so the risk of embolization during stenting is really very, very small. Okay. Should we use ASA to prevent strokes after incidental web? I don't know if there's data. Yeah, Mikol, I don't know if there's data on that. I tend to do it. I tend to tell people to take a small, a low-dose aspirin. I think it's more like a gut feeling. Maybe every day, maybe other day. They're not so uncommon, right? But probably if you think of webs versus FMD, it's relatively, it's very rare to have the classic FMD causing an embolic stroke. A web is different. Web, I think, is much more hazardous. And so I would consider taking a baby aspirin. Okay. There's a carotid stent that we did on our last day. I think we can maybe skip over that. Looks good. There's some anatomical points over there that I think we can skip over. So I don't have time to prepare a little bit more images here. We've been quite busy, and so there could have used some other part of this to recognize the teams that we've been working with. There are really fantastic teams in Lviv and Kyiv and at Dnipro. So shout out to a lot of people there. You mentioned many by name. Maybe do that at the end, but they're doing a great job. Andriy Netluch was really our host and organized a lot of what we did in Kyiv, together with other doctors. There you go, Dr. Salo. They're very, very, it was a great team. Okay, so here's a case. So now we're moving on to Kyiv. There was a question. Skipped AVM. Okay, Nicole is asking, what about conservative approaches to unruptured AVM post-Aruba? Yeah, we can talk about this, for a long time, right, Mikola? I don't know. It's a long discussion. So these AVM, the one particular one, the one I showed, that's indeed, we chose not to intervene on this AVM. One question is like Aruba. We don't, the short answer is like we don't really go by Aruba a lot, which doesn't mean that we don't intervene. It's just, somebody who comes in with intractable seizures or even well-managed seizures, but let's say on 2 anti-epileptic medications, is not necessarily like asymptomatic, right? So there are some issues related to like selection of patients, like what is considered symptomatic or asymptomatic AVM. This was one of several AVMs that we had consulted on in Lviv. All of them had seizures. So they're not necessarily asymptomatic. The one that I showed was like a kind of a deep posterior pericallosal splenial AVM that we had recommended stereotactic radiosurgery for, which I think is not like so readily available, but there are a couple of centers where this can be done. Some in Ukraine, some can be arranged outside of Ukraine, but for that case, we had recommended stereotactic radiation. We also, Aruba, we don't go, basically the short answer is we don't really go by Aruba. We go case by case, and so we do intervene on AVMs that have not ruptured, depending on circumstances. And I think for intervention, I think it's very case by case approach. You can use pre-op embolization, surgical resection, standalone embo, transvenous. All of these options are on the table. If you look at the morbidity of intervention, I think it's important to keep in mind that whenever controlled trials are done, looking at management of AVMs, you see that the morbidity of AVM management is quite high. So touching an AVM can be difficult. There will be, the risk of complication is not low. So I think it's important to, weigh all these options. Okay, so we're moving on to Lviv, to Kyiv. We had, again, front-loaded some of the more complex cases. Now, we're not done in Kyiv yet. So far, we have been to Dr. Shiglov's clinic, where we spent a couple of days. Now we're here today with Dr. Regush. Tomorrow we'll be going to Dr. Kostyuk's clinic for a couple of days. So we're like in the middle of this, so we have other complex cases still to go, but these are the ones we've done so far. So this is a patient that presents with visual decline, basically from mass effect related to this big left paraphthalmic aneurysm. She's having problems with left vision. Now here, one of the things that we do is we spend a lot of time like perfecting imaging. Some of you know that we've done a lot of work in cone beam CT, which is like advanced 3D visualizations. I think it's underutilized. A lot of people obviously use it for like selection of projections for coiling or something like this for aneurysm treatment, but there's a world of information that exists here that we can really take full advantage of. Now, it does require having a machine with these capabilities. It just happens to be that fortunately, when we were here in September last time, we came to Kyiv, we heard that a Siemens Q was being installed in Dr. Shiglov's clinic, and so we were excited about it. It finally, after a couple of, I think, almost 2 years after being bought, it was installed, and so now it came, and we had the fortune of having great Siemens support there, and to be able to work on this machine. And so now, those of you that know like imaging, you understand that like if you're calling something like a Q or whatever, they're not all equal. Like depending, you can get like different detectors, different options, and all kinds of things. So, for example, this machine does not have a micro focus. It doesn't have a micro detector. It has 2 instead of 3. But a 0.4 is the best they have, and it turns out that there's a lot you can do even with this sort of like, it's not the top of the line, but the images can be really fantastic. So I'll show you some of the 3D images that we got, and I think as more and more people hopefully will get these machines, you spend time and you invest into understanding of how to get the most out of them, it can be really quite good. And I think it was very helpful for us to have this information that's available here for these complicated cases. So here's a 3D DynaCT of this case. Here's the A1 segment, MCA, ophthalmic artery, big aneurysm. So the strategy here was basically a stent-assisted or pipeline-assisted coiling. An aneurysm like this, question comes up like, should you coil it, right? Do you need to coil this aneurysm? There's mass effect, should be maybe try not to. I think it's, you have, on the one hand, if you don't coil it, it might shrink like completely. On the other hand, this patient is symptomatic from an enlarging aneurysm causing compression. If we don't put coils in there, there's perhaps, a higher risk of post-treatment rupture, which is often catastrophic. So we kind of elected to go the middle road, put some coils in here. As you can see, this is at the end of the coiling. There's contrastasis inside. We're not putting too much. In our experience, and I think in a lot of other people's experience, the mass effect is really related as much to the pulsation of the aneurysm as it is to like its volume. And so putting a few coils in will allow, if the flow diversion works, if this treatment succeeds, the aneurysm will shrink, not completely, but it will be smaller in size, and hopefully the symptoms will improve. And so we have this at the end. You see that the majority of the aneurysm is no longer filling. We have 2 devices here. Let's go back to this. You see what we did for this case. We have a guide. We have a Sophia 6 as an intermediate catheter. It can be quite good intermediate catheter. Sophia is a soft catheter, but a 6 is, gives you more support than a Sophia 5, and it allows you to do very nice road maps around it. So here we did like a headway 17. We coiled first, and we used some target coils, other coils, and placed 2 flow diverters here of this size. And so in the end, here's the result. Another case, another large aneurysm, like this. Now this one is, go back here. We have a neuron max, we have a synchro, we have a couple of target coils again, phenom, a DAC as an intermediate catheter, which is something else that can be used nicely, and 2 pipelines. Now, I want to show you how, as we go through, basically part of this is to show you as we go through the days, how the cone beam CT images is improving. We're kind of like learning how to use this machine. And so here the image is better than the first one, right? Because we've kind of been like playing with it, discovering a few things, a few tricks to maximize the utility. And so here's a picture like this. So we have 27 here. We put a coil catheter, put some coils. Now here at the end, we had there's some technical questions. One of the pipelines wasn't behaving very well. You see how it's a little bit, difficult to open at the distal end. Dr. Nelson did everything not to take this pipeline out, because we have, obviously this is a precious resource. Everybody from the Ukrainian side knows how precious these devices here are, how expensive they are. And so you really don't want to, remove it if you can. You can at all use it. You were ready to maybe put another one if this didn't work, but in the end, with some skill and use of a J-wire technique, which we can talk about if, maybe later, we were able to get this good result. Now we confirmed that this looked good on a post-procedure Dyna-CT and a post-procedure rotational image, which I don't think I have here, but that's another way to kind of assure yourself that you have a well-opened device is to do a post-pipeline spin. Okay. Any questions so far? See, we have some people here. Dr. Nelson had just walked in. Kim, do you want to say a few words? Maybe later? Okay. Say a few words later at the end, perhaps. Now we're moving on to another case. This was an MCA M1 segment aneurysm, a fusiform M1, right? So basically, like a lot of these were selected for flow diversion. This is kind of a standard setup. You have, a guide for Neuromax, Sophia 6. We used Phenom 21 and Phenom 27. We used several types of flow diverters. Two of them we delivered through a 21, and the third one we delivered through a Phenom 27 using a synchro wire. So here's the final construct. Now when we look at this construct and go back, you see the imaging that we had before the treatment. Like you see, like excellent resolution. And it's important because you have to understand what the risks are. You have to look at these aneurysms. Here's the outflow zone, sort of this like cone-shaped thing. So that helps us decide that we want to put where to land the flow diverter distally, where to land it proximally. If we look at the back side of the aneurysm, we see that both the dominant lenticular striate trunk and this what ultimately turns out to be this sort of like frontal artery are coming from the aneurysmal segment. So we have to incorporate that into our strategy for how we're going to deal with this aneurysm. This is these are some post-reconstruction images. You see, again, it's a post. We did a spin after we deployed these. You can really do a very nice job putting the looking at the flow diverter, looking at the vessel, seeing how good your result is, like where you'd landed these devices. So making sure that everything is done correctly, spending the time to do this. Okay. Questions? Another is an M2. This is a more distal aneurysm right here. An M2 segment. Now also, like you can see that the pre-op imaging involves both 2D DSA and this rotational angiography. Again, very high quality rotational angiogram allows you to understand the details, select the right projections, of course, but understand a lot more about the aneurysm and the associated vessels. This particular one was treated with a Silk Vista baby. If you look at what happens here, there's a loop. Below this loop, there is yet another loop in the lower cervical segment. And so this is a very kind of tortuous path, difficult catheterization. Ultimately, if you go back here, we see that the devices that were used, so we used the Neuromax, a Sophia 6, a Headway 17, which the Silk Vista goes through the Headway 17, Aristotle 14 standard. This is Aristotle wires are excellent wires, a whole family of them. And ultimately, this was the third wire type that we used to get into this branch back here. And this, we use the Silk Vista baby 2.5 by 10. I think part of what we're dealing with is sort of the limitations of tools. I would have preferred to use a 15. This is a little bit shorter, so we have to land it precisely, and you can see how it opposes the aneurysm extremely well here, and all of the projections you can show you later. But we had the 15 that we'd used up, and so we were using this 10, which I think did a good job in this particular case, given the selection. Any questions about this? Now there's a couple of other cases. Web device is an option, Michael says. I think so. I think web device, yes, web device would be an option. If you look at this kind of aneurysm, it might be, all of the projections, I think you get a pretty decent result. Could you have a residual neck with the web? Potentially, yes. I would say this, that once we had kind of got up to this aneurysm, we realized how difficult the catheterization was. You probably deploy a web through a 17 catheter. It's just about big enough. The other option is, instead of using like a flow diverter, you can use stent-assisted coiling, either by jailing a microcatheter, which probably would have been kind of difficult, even though that would be preferred. You can use like some sort of stent, like an Elvis. What we have in the States is like flavors like Elvis or Atlas. Atlas is laser cut, Elvis is braided, Elvis Jr. So I think that would have been other options to use. And I think there are even more options are coming out. So there's a contour device that's being investigated. And there are other things that can be done. Okay, so here's a paraphthalmic aneurysm now. This one we treated with 2 flow diverters. We had a discussion about whether or not 2 is too many, or should we use just 1. Again, I think it goes to sort of the heart of like thinking of what is medically right versus what's possible. I think it's fortunate that we had the possibility of using 2, because medically I think from the interventional perspective 2 is much better here. And so that we were ultimately able to do that. You can see that the anatomy here is kind of like something that we see not infrequently. We see that there's a dilatation of the vessel here, this paraphthalmic aneurysm. But you see how the whole vessel is a little bit dilated here. Sort of speaks to the dysplasia of the artery, the underlying dysplasia that gives rise to this. This is like a saccular aneurysm, but the whole vessel is diseased. And it's a little bit larger here, so you want to size the pipeline to this X, say it's like this to this, where I'm showing the pointer. You want to size it to this particular segment, because we want to oppose it to the neck section of the aneurysm here that required using kind of like some bigger devices. So in the end, we ended up using like a 425 and a 5. It's also good if you're overlapping them, which I know that this is something that's almost never done here. But if you're going to do it, it's good to have devices of different diameters so that the overlap of the braid is less exact and you have more flow diversion. Sometimes they just sort of use the same diameter. They kind of overlap exactly and don't get, you don't get too much more coverage than if you used 1. So here they're substantially different in diameter. That we have good coverage. This is what it looks like in the end. You can kind of really see very well how it's expanded in this segment, that it's opposing the neck right here, and we're coming around here, and we don't have a problem with like T-boning or any stenosis, the proximal aspect. Was another M2 aneurysm that we treated like this. Come back here. We used our shortest pipeline at 2.5 by 10. And again, like catheterization can be kind of hard. With this sort of trajectory, it allows 27 to come into distal vessel. And then you can deploy a short, strategically placed device like this. I don't have a lot of images. I only was able to take 1 image of this case here. Go back and get some others. You want to keep record of what we're doing. But basically, this was an aneurysm that was treated with placement of Silk Vista baby and coils. And as you can see that there is some clot inside here, right? If you see how this looks, you see that there's like some clot. Now this happened, thank you. Thank you, Alex. Right there, that's the pre. And so here's the post. Alex, thanks a lot. So you can see, if you go to the chat, you can see what this looked like before. If you look at this before and you look at this after, obviously there is clot in here, right? And so, okay, somebody's in dual antiplatelets, you're doing this, you know what to do if you don't have like an IV version of 2B3A. Fortunately, they had, it's available. Now what happens if it's not? It's a big problem. I think humanitarian groups can maybe help with that, but I think this problem would have to be solved, for the country. It's going to be difficult to do these cases without this backup option. Probably are looking at 2-3% in the best of all worlds incidence of like acute, intraprocedural thrombus formation, even with Brilinta. Used to be higher. I think probably before we had Brilinta, if we were using, say, clopidogrel, and we weren't testing, if you just kind of use clopidogrel, given the kind of resistance you have with that, we're probably looking at 6-7% thrombotic complication risk. Now it's down substantially with newer agents, but it's that's still the most common complication of flow diversion. So I think there's something that needs to be addressed. Today CT, yes. So you see this CAT scan, there's a small infarct at the anterior temporal lobe. If you go back to this picture, you can kind of see, it's a little bit difficult to see, but it's an oblique view. There's a vessel coming off the back. And we have a very good rotational image. We have a very good cone beam CT where you can see that there is an artery that's coming out of this aneurysm that we had purposefully occluded with coils. It's on the right side, right temporal location. Expecting to have some collaterals. We had partial collateral support that we injected from the vertebral artery, but not full collateral support. So we kind of took a decision that we were going to take the possibility of a right temporal infarct, which is usually well tolerated, to be able to occlude this aneurysm. So far we have just like kind of at the tip here. The rest of the, you can see that the rest of the temporal lobe is okay. And so we know that the device is patent. Okay. Now we have just one case. I think we have time for some questions. We can show one last case that we just finished here, or maybe we can hold off on that, but this was a particularly complex case that we did with Dr. Regush. This is a patient that has a P1, P2 segment aneurysm. It's also a little bit complicated. You have a right carotid injection. Here's the A1, here's posterior communicating artery. Back here, you see an aneurysm. There's a kind of a fetal PCOM. I'll show you some more images later. You see reflux into this basilar artery from a P1 segment. Here's an injection of the right vertebral artery, SCA, small P1. There's a P1 segment here that's coming into the aneurysm. Here's the P2. If you look at this, it might be a little bit easier to understand what's going on here. ICA, A1, A2, PCOM, aneurysm, P2, reflux into the P1, and here's like a little wisp of the basilar. So this is another complex aneurysm. It's much larger. This is the cap of the aneurysm. There's partially thrombosed state here as well. Here's the lateral view. Now, this kind of goes back to, if you finish with this case, it kind of goes back to the very first case and that fusiform basilar case that we showed. Again, thinking about strategy, like that. The idea is that if we were to use flow diversion and put a device from the P2 to the P1 to the PCOM here, could could this be enough or not? And the answer is, it's not going to be enough, because if you really work this out, you realize that this P1 is coming into the aneurysm at a different angle, such that we will not be able to oppose it with the flow diverter, and this P1 is going to keep the aneurysm alive. So the treatment has to involve both flow diversion and closing the ostium of this P1 segment, which can be tricky to do interventionally. And it also poses a particular risk. And the risk is that there are often perforators coming from the P1 segment that are eloquent thalamoperforators, long collicular or like collicular type perforators that go to the back of the brainstem, the collicular plate, the cerebral peduncle, basically like a bunch of eloquent areas. And so the strategy was basically to catheterize from the PCOM to the P2, place a second microcatheter, so again, dual access femoral to the carotid artery, radial through the right vertebral artery, microcatheter in here, put some coils in here and close the P1 segment. So the angiogram here is like an oblique view that of a dual injection, an injection from the ICA and from the vert. So you can see everything sort of together. PCOM, P2, aneurysm, P1. The catheterization was a bit challenging. Again, there's a 27 catheter. We're doing a loop-to-loop. We were able to do that. And so ultimately we have a look like this. Now, this is a 27 phenom. 27 phenom does a very good job at sometimes you're able to just spontaneously reduce it without having to, deploy a stentriever here or a balloon or something like this. Just if you have distal enough catheterization, sometimes trying that, pulling the wire back and reducing the 27, sometimes, works by itself. And indeed, that we were able to do that. So we pulled it back, we did a control injection from the right carotid. We do an injection also from, the intraaneurysmal injection with the microcatheter. We see the outflow. And so now we're in a position, here are some still shots of advancing a flow diverter, which is 275 by 14 pipeline, placed like this. Now we still have a microcatheter trapped in the aneurysm. So for subsequent coiling, we're injecting. Now once we inject, we have a 27 that we pull back to the PCOM. We inject that, you see this really hazy. There's a lot of flow diversion here, so it's kind of like we've changed the hemodynamics inside this aneurysm. We can show you this a little bit better like this. You see how slow the inflow is and how really different it looks. There's a thalamoperforator that we're identifying here coming from the PCOM. So there's a lot of anatomy. This particular machine is a Philips, and we used a vaso-CT. Go back to these two images. We used the vaso-CT IA version of that. And as you can see, there's a 20-second injection, so it does take a lot of contrast. So if someone has renal insufficiency, you probably don't want to do this, but if they don't, and if they're under general anesthesia, and they're not moving, you can get very good images like that too. And you can see, I don't have all the pictures here, but basically, when you look at this, you see this little dot here. This little triangle is basically like a tiny little infundibulum of a right anterior thalamoperforator coming from this P1 segment. So we knew where our sort of back zone was, where the safety was. If we're going to close this with coils, you come back here and you can see this, look, it's overlapping here, but there's an anterior thalamoperforator coming from this segment here. Pipeline. Here's at the end. So at the end, when we're injecting the vert, here's that thalamoperforator right here. It just took a very small, target nano coil, a very, very, it's a, there's a 1x3 nano. You can kind of pack them really nicely in here. We put a couple of other coils there, and into the aneurysm. Not a lot, again. Mostly what this involves is just like closing this P1 segment. And I think that's risky. Like one of the biggest risks with this case is where this coil ends up. Like hopefully this perforator stays open. And hopefully there's not like another one down here that we might not have seen. So we'll see how this person does clinically. We just finished this case a few hours ago. And so remains to be seen. So far, seems okay. The last picture, there's a couple of others I can show you, but basically this is what it looks like at the end. Okay. Well, I believe this is our last case, a report of things being done. Now, what time is it? All right. So let's open the floor. If there's any discussion, if there's any questions, please ask them. Some cases are complex, some are a little bit less so. If there's any, there's any feedback, things you agree with, things you do differently, what else? Let's talk. Okay, let's see if anything comes through the chat. We have, this is about like the halfway of our mission here. Been a week. We're gonna have another week, more work to do. So we're excited. I think it's been like a really amazing partnership with multiple, it's too many, so many people to mention. That we've been working with, and we're going to continue to hopefully build more partnerships, doing more work. We want to thank everybody, thank RAZOM for enabling this. I'd like to thank the many people that contributed our tools, our implantable devices. Individuals, companies that have generously donated many things. For example, just specifically to mention Medtronic for a very generous donation of 20 pipeline devices for this mission, which is really incredible. I'd like to mention Scientia, which is the company that makes the Aristotle wires. And some other like good products. The Aristotle wires have been fantastically successful in the States and wherever they're sold. So I think that's, they've been very generous. Bolt and Bolt-On, sister company in Poland. Bolt's been super generous with giving us Silk Vistas and other devices, and many, many other individuals, people have contributed to make this happen. So I want to thank everybody. I'd like to thank Alexander. Alexander has been with us in this trip and in the trip before. Really thankful to him for all his support and for everybody's support. Mikola, yes, thanks. See if Kim is around. I've been really fortunate to have Kim Nelson as my mentor throughout my career and here as well. Like, if you know Kim Nelson, you know what I'm talking about. One of his many fantastic qualities is he's an incomparable teacher, and to teach someone with extensive experience with proctoring, teaching people in many different countries in different circumstances. This is really an art that few people master, and he's can certainly be a professor of worldwide teaching, many things. Okay, let's hang out for another minute or two, and then if there's no questions, we'll call it a day. we will have this recorded, and so hopefully we'll have this available in English and in Ukrainian for people that that prefer to hear it in Ukrainian.
Maxim, could I just say a few words for you? Do you hear me?
Yes, of course.
So
yes.
Thanks so much for such fantastic cases. Some of them are really so complicated. So you explain it shortly, but many details are left unknown. So we see what quality of your and Kim's understanding of pathology, of anatomy, of using of instrumentations. We really admire from your experience, from your fantastic technique, and special words we want to express to you and to Kim and to all team RAZOM, the great job that you are doing for us, for our teaching. Many patients just waiting for a long time for your coming and in order to get this chance for using such expensive instrumentation for really hard pathology. So from our community, neurosurgeons and interventional neurologists, I want to express great thanks to you, to your team, and to all people whom you mentioned who was involved in a realization of this fantastic project, and hope it will continue in the future. Thanks so much.
Mike, thanks a lot. Thank you very much. And thanks to everybody again. Alexander Komarov, thank you to Lilea, who was our coordinator and our fantastic helper from RAZOM. Yulia Shama, a lot of people, obviously too many people to thank. I want to recognize them all. It really, when you think of these missions, it takes so many people to enable this to happen. And so we're really standing on the shoulders of so many people and organizational giants. This is to go anywhere like this is hard. Obviously, to go a country like Ukraine, with all the challenges here, with the obvious challenges of the war, to enable this to happen is really, is really a feat. So, anyway, I want to thank everybody for joining. Please spread the word that we will send out, notifications when the recording is available, when you can have them online. We'll continue. We have more cases to do and more work to do, and then we'll perhaps, at some point we'll have a second part of this to report on the rest. Thank you for joining, and have a safe day.